A very good evening. So myself, Dr. Ramyasree B. I'm a NEET PG educator for OBG-2. So welcome to the platform of Unacademy. You have a lot of things on the Unacademy like the Plus subscription, daily live classes, structured courses, live tests and quizzes, unlimited access, and there are plenty. You take an access for one, you have a plenty access to so many things happening in the Unacademy when you take a Plus subscription. And you also have iconic subscription where you can both the Unacademy as well as Prep Ladder you can use for both of them. So yes, I'm also doing free live classes on Unacademy NEET PG. So previous 2 days, yesterday and today, I'm doing the UPSC series. So you all are aware UPSC exams are there on 22nd October. So for that purpose, yesterday I have done UPSC 2019 question paper discussion. Today at 12 PM I did UPSC 2018 question paper. Tomorrow again I'm going to do the UPSC previous year questions. So every day at 12 PM I'm doing on the Unacademy NEET PG category. You have to just go for the special classes, search my name and you can enroll for that. Okay. So they are free classes. Access is available for any number of students. And you also can attend the free live tests on the Unacademy every day at 9 PM. Link is present below the in the description. So you daily have a series of 20 questions. Okay. At 8 PM also you have NEET PG T20. How do you have to check for this Unacademy learning app? I know it's a fab, so you get so many things. So first you can use all the free aspects of it and then go for anything where you have to get a subscription. So you have to just type for the Unacademy learning app, and once you have the Unacademy learning app, install it. Then you can see this is the special classes is the one where we take the free. So you can search for that first initially, and then if you like you can get a subscription. Simple. And you can also use my code Dr. Ramya YT to get a 10% discount. So very good evening to all of you. Good evening Imran, good evening Ansuya. Let's start with the session. So I'll be discussing MCQs here, definitely beneficial. Let's start with the first MCQ. A 48-year-old woman presents with intermenstrual bleeding for 2 months. Episodes of bleeding occur any time in the cycle. This is usually fresh red blood and much lighter than a normal period. It can last for 1 to 6 days. There is no associated pain. She has no hot flushes or night sweats. Why are they mentioning there is no hot flushes and night sweats? Because they just want to tell us this intermenstrual bleeding is nothing related to menopause, right? So she is not having her menopause yet. She is sexually active and has not noticed vaginal dryness. So that again telling us this is not a vaginal atrophy or endometrial atrophy. She has 3 children and has used the progesterone only pill for contraception for 5 years. Her last smear test was 2 years ago. All smears have been normal. She takes no medications and has no other relevant medical history. Identify the cause, and this is the USG image, and you have to tell what is the diagnosis of this. Excellent Imran, you are correct. Wonderful. History also tells us many things. So yes, it's just telling us that she is not having menopause. So ideally, whenever they have postmenopausal bleeding or intermenstrual bleeding, the most common cause of postmenopausal bleeding is what? Postmenopause, vaginal atrophy or senile endometritis. So that is what he's trying to rule out for you. But actually if you see in the image, you have a mass So this is the uterus, and we can see that mass is arising not from the myometrium, it's arising from the endometrium. A mass arising from endometrium and huge. Excellent. This is an endometrial polyp. This is a endometrial polyp. Usually endometrial polyp can be confused with fibroid polyp. Endometrial polyp can be confused with fibroid polyp. How do we differentiate endometrial polyp and fibroid polyp? Very important. So endometrial polyp is echogenic, whereas fibroid polyp is hypoechoic. Hypoechoic means they look black color. See, this is not black, this is white. So this is echogenic. This is echogenic. Both are homogeneous. Even fibroid also looks homogeneous. Endometrial polyp also looks homogeneous. So endometrial polyp is echogenic, whereas fibroid is hypoechoic. Endometrial polyp projects into the endometrial lumen. Fibroid distends the uterine cavity. Now you might ask me, why is this looking like uterus is distended? This is actually saline infusion sonography. So you can see this there's some fluid here, that is the saline. Saline infusion sonography helps you to delineate the endometrial polyps best. Stalk may be identified by saline infusion sonography. Fibroid they are broad based. Very important is the feeding vessel sign. Actually in NEET 2020 you got a question about this feeding vessel sign. So you will see in endometrial polyp only one vessel entering into the polyp. Okay. Whereas fibroid it is peripheral vascularity on a Doppler. Fibroid it is peripheral vascularity on a Doppler. Okay. So endometrial polyp presents to you with intermenstrual bleeding, and usually it will be fresh red blood. Fresh red blood, right? You can identify it with saline infusion sonography or a TVS, better delineated on a saline infusion sonography. What is the gold standard for identifying the endometrial polyp? Gold standard. Gold standard is hysteroscopy. Treatment is, because I can see directly, right? And treatment is also hysteroscopic DNC. Treatment also is hysteroscopic DNC. Okay. Excellent PS. Next question. A HIV discordant couple desiring children, a counsel regarding the risk of viral transmission. What does a discordant couple means? One of the person is positive for HIV and the other person is negative. So obviously when they're having an intercourse, there's definite chance that the husband can transmit to the wife, or wife can transmit to the husband. So if they're having intercourse, there is a risk of viral transmission. Now but they want kids. So how can they have the kid? Even kids should not get the transmission. So which of the following information is correct? Only IVF can be performed if the infected male partner's sperm is to be used. But there is also, okay, semen washing and artificial insemination is a safe option for both female partner and offspring. The couple should defer pregnancy in order to avoid the risk of viral transmission. The only safe approach is to use sperm of a healthy matched donor. So here he is mainly considering that the wife is negative and the husband is positive for HIV. So in this discordant couple, what can you do to prevent the transmission to wife as well as for offspring? Healthy match donor. Okay, so I see some of you answering B, some of you answering D. So the appropriate answer here, majority of you are answering D actually. The correct answer here is B. See, healthy match donor, then what happens is it won't become the genetically offspring of husband, right? So we avoid using, when they don't have sperms, we probably would have gone for another donor. Now you can ask me, if I take the husband semen, there is a risk of HIV transmission to the fetus. So how can we stop that? So what we do is, we all know that before doing IUI, we do semen wash method. So during the semen wash process, we try to irradiate the semen sample and we get rid of all the viruses, not only HIV, HCV, all those viruses we try to get rid of, right? And then we take only 0.5 ml of highly motile sperms free of the infection, and then we inject it into the uterus of the mother. So we can do semen wash and artificial insemination. So that way it is safe for both mother also, safe for the baby also. So during the process of semen wash, we can eradicate the HIV virus from the semen. Right? So the best answer here is B. Raloxifene is a SERM. What kind of action does this drug have on endometrium, breast, bone? Okay, so let's see the answers which are popping out. So I have C. Right. So raloxifene is a type of SERM where it is agonist to estrogen at some places and antagonist to estrogen at some places. On endometrium it is antagonist. Excellent. On bone it is agonist. On breast it is antagonist. 100% correct. So the answer here is antagonist, agonist and antagonist. So it is a C, the best option. Now let's see about the other SERMs also. So we have tamoxifen, tormifene, raloxifene. We also have ormelexifene and we also have clomiphene citrate. Clomiphene citrate is used for ovulation induction, whereas ormelexifene is used as Saheli emergency contraception, or we can use ormelexifene as Chaya. What is Chaya? Nice names, no? Chaya, Saheli. Chaya is used as a once a week pill. Those are the other two SERMs. Now here tormifene we don't use much. Tamoxifen and raloxifene, let's see the differences. Tamoxifen and raloxifene both has the risk of hot flushes. Tamoxifen is agonist to uterus. So tamoxifen has a side effect of endometrial carcinoma, but raloxifene has no effect on the uterus and it is antagonist on the uterus. So it increases the risk of endometrial cancer. Next, prevention of postmenopausal bone loss. Yes, tamoxifen acts like a estrogen. Even raloxifene acts like an estrogen. So that's why raloxifene is used in the treatment of osteoporosis. But as such, postmenopausal osteoporosis, which is the first line drug, you can answer in the comment box. Both of them decrease the risk of breast cancer. Favorable pattern on serum lipids. Tamoxifen and raloxifene both have favorable pattern on serum lipids, but raloxifene actually has a chance of venous thromboembolism. It's not so favorable on the serum lipids. Raloxifene increases the risk of venous thromboembolism. That is one side effect associated with raloxifene. So you are all correct by answering antagonist, agonist and antagonist. But please remember raloxifene has a side effect of venous thromboembolism. Okay. Am I audible and visible? Oh, I'm audible and visible. Good. There's a lot problem going on with our net current everything today, so it's little problematic only. Okay, so as I'm audible and visible, I would like to continue the session. Next question. A 28-year-old amenorrheic woman who wishes to become pregnant attends the fertility clinic complaining of galactorrhea and mild visual disturbances. Her serum prolactin level was found to be elevated. An MRI scan of the head is performed, which showed the presence of macroprolactinoma but without suprasellar extension. What is the most appropriate first line management? Bromocriptine, quabargolin, quinabolide, radiotherapy. Right, so I have the answer of cabergoline as of now. So I have few students answering A, few students answering it B. Right, so first and foremost, she is 28-year-old. And next important point here, what we have is she is 28-year-old. She wants to become pregnant, so she is infertile. I think the diagnosis is very clear that we are speaking about the prolactinoma. The simple question here is, when you have prolactinoma plus infertility, what is your drug of choice? Prolactinoma plus infertility, what is the drug of choice? Is it cabergoline or is it bromocriptine? Another point, actually this is macroprolactinoma. Macroprolactinoma is more than 1 centimeters. But this doesn't have suprasellar extension. It means it is not causing the, it is not pressing the optic chiasma. So still she didn't develop the bitemporal hemianopia, but she has some mild visual disturbances. Even for macroprolactinoma, before surgery, you have to try with medical management. Even for macroprolactinomas, before surgery, you have to try with medical management. And please remember, whenever you have a prolactinoma with infertility, the drug of choice is more for bromocriptine. Pregnancy and infertility, prolactinoma, the drug of choice is bromocriptine. Non-pregnant patients, it is cabergoline. Or those who don't want to conceive, for them it will be cabergoline first line. But pregnancy and infertility, the first line is bromocriptine. So A is the answer. A is the answer. Following a spontaneous miscarriage at 8 weeks gestation, a woman is referred to the gynecology clinic with persistent irregular vaginal bleeding. What initial investigation should be performed? Endometrial biopsy, pelvic ultrasound scan, serum beta HCG level, urine pregnancy test. She actually had a spontaneous miscarriage, but she's still having persistent irregular bleeding. Usually after a spontaneous miscarriage, normally by 1 week they stop bleeding and everything gets over. It's like a period. But this female is having persistent vaginal bleeding. What initial investigation should be performed before you go for will it be serum beta HCG or something else? Whenever you have a persistent irregular bleeding post delivery or post miscarriage, what are you suspecting? There are 2 or 3 differential diagnoses. Who can answer those? Number 1, I'm suspecting retained products. Number 2, I'm also suspecting it can be a choriocarcinoma or persistent GTD. The first thing which I'll do to rule out the choriocarcinoma and persistent GTD is do a urine pregnancy test. Do a urine pregnancy test. The first thing which I'll do is do a urine pregnancy test, not pelvic ultrasound. See, first, see, I have to rule out for both of them. I actually will do pelvic ultrasound as well as UPT, both. But which one I'll do first? See, UPT can be done in a minute here in the OPD itself. For scan, I have to take her to the scan room and all. So first I'll do UPT and then I'll go for an ultrasound scan. So which initial investigation should be performed? It is the UPT. Very good, Sayan. You're correct. So we have to rule out the choriocarcinoma and persistent GTD. So for that I'll do the UPT. If UPT is positive, normally UPT will become negative by almost by 2 weeks for a post abortion. But after 2 weeks also, if it is persisting, then you have to go for the serum beta HCG level and all. Okay. A 30-year-old woman attends the gynecological clinic with discomfort in the left iliac fossa, and clinical investigation shows a pelvic mass. An ultrasound scan is arranged which demonstrates a simple cyst in the left ovary with a diameter of 45 mm. The right ovary of the uterus appears normal. What other investigations is required? Alpha fetoprotein, CA125, beta HCG, no investigation required. If UPT, so I have a query here from Sayan that do we require to monitor beta HCG? If UPT comes positive, then 100% you have to monitor the serum beta HCG levels to see whether there is a rise in beta HCG, serial rise in beta HCG or a plateau in beta HCG. Till it becomes 0, you have to keep monitoring because it suggests she is going into GTD or choriocarcinoma. So I have to give her prophylactically methotrexate because GTD or choriocarcinoma can occur even after an abortion also. So you have to monitor them weekly till it becomes 0. So this answer here is no investigation required. Which is the most common ovarian cyst in a reproductive age woman? Most common ovarian cyst in reproductive age women. Chocolate cyst, no, neither serous, nor chocolate, neither serous. There's a little disco going on behind me. Sometimes light comes, goes, but as of now I'm lucky enough that a class is going on. Very good, excellent. The most common ovarian cyst in reproductive age group is follicular cyst. They are functional cysts. Actually, if somebody has attended morning class, we had some question on the follicular cyst. So they are follicular cysts or the functional cysts. They are the most common. And usually these are simple cysts. So they are unilocular and homogeneous. So unilocular, homogeneous, functional cysts less than 7 centimeters, no need to do anything. I think you all know this when an ovarian cyst is less than. So remember this, even in your dreams also you should answer. Matlab, so many times you get questions on that. Less than 5 centimeters. Simple ovarian cyst, just wait and watch. Most of the time they regress by themselves and most of the time they are asymptomatic also. So they will be simple, unilocular, homogeneous. Endometriotic cysts usually can be unilocular but they will have ground glass appearance. Okay. If they are between 5 to 7 centimeters, if it is simple cyst, wait and watch. If it is a complex cyst, go for surgery. If you have more than 7 centimeters, go for surgery. Okay. So most common is follicular cyst. More than corpus luteal cyst also follicular cyst. Pregnancy may you will have corpus luteal cyst. So much mixed masala, no? If somebody asks you which is the most common benign ovarian tumor in reproductive age women, then or in a young age woman, then your answer would be dermoid. But most common ovarian cyst is follicular cyst, which is a functional cyst, and less than 7 centimeters also you don't require to do anything if it is a simple cyst. Your answer would have been CA 125 if the age of the woman was more than 45. Postmenopausal, go for CA 125 because you have the risk of epithelial ovarian cancers. A 5-year-old girl is referred because of Tanner classification stage 3, breast development, pubic hair growth and irregular uterine bleeding. She also complains of occasional right-sided abdominal pain. Based on her history, what is your first line of investigation? Abdominal MRI, gonadotropin challenge test, pelvic ultrasound, serum estrogen. Difference between theca and follicular cysts. So, by the appearance, follicular cysts are unilocular and homogeneous. Thecal cysts have cobweb appearance. I actually have the pictures of them. Probably next time I'll show you. I'll try to keep one spotters, all USG spotters. So, I'll just put the pictures. You have to keep answering. Like that we can play once. So they'll have cobweb appearance. You know, there will be small webs formed inside in the theca luteal cyst. Corpus luteum forming the cyst goes for theca luteal cyst. Excellent. This you would like to do the pelvic ultrasound. All of you are answering correct. So 5 years having Tanner stage 3, breast development, pubic hair growth, irregular uterine bleeding. This is all called as precocious puberty. Definitely abnormal. Now precocious puberty can be both central or peripheral. Most of the time central is most common. Central accounts for 80%. Peripheral, that is ovary producing or liver producing estrogen, all that will be another 20%. But most common cause is constitutional. In family only it is running that they'll all have early. Or idiopathic. Most of the time we don't know what is the exact cause. Constitutional or idiopathic is the most common cause. Now here she has breast development, she has pubic hair growth, she has irregular uterine bleeding, and she also complains of right-sided abdominal pain. This raises the question of probably it's a hormone producing ovarian tumor. So as I am suspecting hormone producing ovarian tumor, my first investigation would be doing an ultrasound. So in the ultrasound I will be able to pick up an ovarian cyst where I can use the tumor markers to come to know the diagnosis of which germ cell ovarian tumor, which germ cell or sex cord stromal tumor is that. So probably this is a sex cord stromal tumor, not a germ cell, because it is a hormone producing. But they coming at so young age is also little on a rarer side, but yes, can be possible. Next question. A 20-year-old young girl presents to the clinic with primary amenorrhea. She has a female phenotype, height 150 centimeters, poorly developed breasts. Further evaluation was done, vagina was present on examination. Ultrasound revealed normal uterus but gonads weren't detected. Further evaluation done shows 46XY karyotype. The most probable diagnosis is androgen insensitivity syndrome, Noonan syndrome, true hermaphrodite, Swyer syndrome. Very good medic freak, excellent. McCune-Albright syndrome is also associated with precocious puberty where we have polyostotic nodules, maculite spots, something is there, and they have precocious puberty also. Excellent. So this is a Swyer syndrome. So I make it a small table, you know, so that you can revise it again later also. This is one simple funda. How do you identify the secondary amenorrhea disorders? I divided it into two parts. If uterus absent, secondary sexual characteristics present. Uterus absent but secondary sexual characteristics present. If it is 46XY, close your eyes and answer it as androgen insensitivity syndrome, where axillary and pubic hair is absent. If it is 46XX, then it is MRKH. So uterus absent, secondary sexual characteristics present, 46XY, AIS, 46XX, MRKH. If uterus present and secondary sexual characteristics absent, matlab ulta of the first scenario. 45XO, it is Turner's. 46XY, it is Swayer's. Simple. This will help you to answer most of your MCQs easily, no? In Turner syndrome, all of the following are true except streak ovaries should be removed surgically due to the risk of malignancy. There is increased FSH levels. Female internal genitalia present, has normal but infantile external genitalia. So Turner syndrome has streak ovaries. Streak ovaries, no estrogen. So no estrogen, no negative feedback, so increased FSH levels will be present. Internal genitalia development is decided by presence or absence of AMH. So in Turner's, it is ovaries, not testes. So AMH is absent, so female internal genitalia will develop. External genitalia development is decided by testosterone, in utero exposure to dihydrotestosterone. So as Turners don't have in utero exposure to dihydrotestosterone, they have normal internal genitalia, but they are small. They have normal but small infantile external genitalia. Okay. These gonads don't have the risk of malignancy. Which gonads have the risk of malignancy? The gonads which have the risk of malignancy are Swayer's or AIS. Those gonads have the risk of malignancy, not Turner's. Okay, so they can be left behind. So about Turner's, it's always good to know head to toe everything about the Turner's. So I'll quickly speak about the Turner's head to toe. So they have low hairline, low set ears, webbed neck, shield-like thorax, cardiac defect, broad chest with widely spaced nipples, cubitus valgus, horseshoe-shaped kidney, short fourth metacarpal, and they have a small height. They don't have secondary sexual characteristics and they have infertility, right? And the cardiac defect they have is coarctation of aorta with bicuspid valve. Coarctation of aorta with bicuspid valve. And what is the treatment which you are supposed to give to Turners? So treatment is you give them HRT, hormone replacement therapy. You give the HRT, that is hormone replacement therapy, with estrogen and progesterone. We give both progesterone also, estrogen and progesterone, because only estrogen will help in the development of secondary sexual characteristics, but only estrogen can increase the growth of the endometrium and land them up in the risk of endometrial hyperplasia. So I'll give both estrogen and progesterone. I'll also give her growth hormone supplementation because she has a short height because of the mutation of growth hormone gene. So you can supply them with growth hormone also so that they'll have a good height. Okay, they're also prone for autoimmune disorders like diabetes, thyroid, so you have to do the screening for those also, right? So that was today's session where I tried to discuss some of the questions. Next set I would plan to keep image spotters. So I just put the image, you have to answer, and I'll put a question. I will not give you options, so it's like a spotter. You have to keep up, you have to go on answering what are the possible answers which you can get. So probably 15 spotters or 20 spotters in half an hour. I think that would be awesome. I think that plan will definitely help us to make us more perfect with the image based questions, because some of you always have that fear of image based questions. So we'll do next session that way. Okay, I'll just put you all the link also once I take the slot, right? Thank you guys, all the best, keep studying, and don't forget I'm doing UPSC series. Tomorrow again we'll have a discussion of the previous year questions at 12 p.m. daily at 12 p.m. I'm doing the UPSC series on Unacademy Learning app. So you have to just join there and click for my special classes. You will definitely get to know it. Thank you guys. Every day, today is what day? My all sessions, if you have observed, I kept it on every Wednesday 5 p.m. I'm taking the session. Every Wednesday 5 p.m. I'm taking the session. So next session will be again next Wednesday. Okay. Tomorrow 12 p.m. I'm having the free class Raj YT Gamer. So it is tomorrow at 5 p.m. 12 p.m. I'm having. Daily at 12 p.m. on Unacademy Learning app free classes. Okay.